Okay. Thank you, Dr. Tanuj and AOS and APGC for the invitation. So this is, we know that congenital glaucoma presents in a huge variety, and they present with a mild problem to a very severe problem. And we deal with several of these situations, and especially when it comes to India and some parts of Middle East, we do have a lot of patients with difficult diseases who come. So there are several choices for the treatment of pediatric glaucoma, starting from the angle-based surgeries to the subconjunctival surgeries and the implant surgeries, and in some situations, also the laser procedures. So the common question that is asked is, how do you choose? I think the answer to this is not simple. It is very complex, and we all go by a case based situation. On an individual basis, we choose. It depends on the type of glaucoma, depends upon the age of the child that presents with the disease, and also associated ocular comorbidities. What is unique in infants is that these eyes are large, majority of them have very hazy corneas. Because the eyeball becomes large and ophthalmic, they also have a significant amount of scleral thinning that could be localized or generalized, distorting the angle and distorting the anatomy of the limbus as well as the eye itself. And several of them can also have distorted anterior segments. We know that medical treatment has a very limited role except in certain types of secondary glaucomas because of the significant angle anomaly. And this basically is a surgical disease. Surgery is the mainstay of treatment and the definitive treatment. First surgery is always the best choice. So one has to choose a good surgery or a best surgery in that person's hands so that whatever success we achieve, it needs to last long because children have a very long life to go. So corneal clarity plays a very important role in these eyes. So operating children with congenital glaucoma is quite challenging. And it would always be advisable for trained specialists with higher volume centers who would operate because they have definitely greater experience in handling these children. Not just the surgery, but post-operative management, whether it is in terms of amblyopia management or additional procedures that some of these eyes would require, like a keratoplasty and sometimes even the vitreoretinal surgeries would be possible if they are in a tertiary care center. Frequent follow-ups as well as need for examination under anesthesia and rehabilitation both for amblyopia as well as visual rehabilitation has to be an integral part. So once in a while, if somebody needs to operate, I think they need to really think. They could assess and help in post-operative management, but surgeries should be a choice that should be possibly given to people who have a greater chance of seeing them or operating similar type of cases. So the types of glaucomas that present when the child is very young is essentially primary congenital glaucoma, which is the major chunk. Also, those glaucomas with anterior segment anomalies and certain acquired diseases also present quite early in age. So like I said, the ocular changes of corneal clarity, the corneal diameter, and the anterior segment distortion. Sometimes you may also have subluxated lens, you may have iris tissues that are abnormal. So all of these play a very important role in choosing the type of surgery. Less than a month's age when the child presents versus the child presenting greater than 1 month until 2 years and greater than 2 years, because we know, especially in India, congenital, we have children with congenital glaucoma. That means glaucoma present at birth, but children present to us, or the parents bring the children even beyond 2 or 3 years of age. So it's not uncommon for us to see, although it is a glaucoma that was present at birth, but they do present quite late. So conventionally, we do angle-based procedures or combined trabeculotomy with trabeculectomy. And if it fails, we go for repeat trabeculectomy or drainage implants and cyclophotocoagulation. Angle-based surgeries, usually when there are no other ocular anomalies and the child is greater than a month and less than 2 years of old, they do well. And so when the corneal clarity is good, it should not be a problem at all. But very large corneas or presence of a corneal haze, it becomes difficult to do. Hazy corneas, one of the things that's very important is to identify what is behind this hazy cornea. So this is something that's very important because this could be a primary congenital glaucoma with a grade 5 corneal edema, or it could be an iridia that's presenting with a corneal haze, or a severe anterior segment disease, or a congenital aphakia, or a Peters anomaly. So we don't know what is there behind the cornea. So it's always a good idea to try and evaluate them so that you can plan an appropriate procedure. At the same time, helps to prognosticate with the parents as well. So combined trabeculotomy and trabeculectomy is the common procedure that we perform because several of our children present with hazy corneas. Having said that, some of these, at least because of the early presentation these days, we do see children who come with a little less severe disease. So we are able to do angle-based surgeries. You can see after the corneal, after the trabeculotomy and trabeculectomy, some amount of corneal clearing, and you can see a dilated fixed pupil in this eye. So this child actually later on underwent keratoplasty and is doing well. So, like I said, these children, because of the corneal haze that they have, even if the primary surgery is working well, sometimes after this additional procedure like a keratoplasty, or some of them may require a cataract surgery, the primary surgery may fail and one may require to do a repeat intervention. So we should be vigilantly following them up because they do require multiple procedures as time goes by. Glaucoma drainage devices, we generally avoid doing them as a primary procedure in primary congenital glaucoma, but in certain situations where they are secondary type of glaucomas where they are difficult anterior segments to manage, in such situations, they are also used as primary procedures. Both valved and non-valved implants are used. Again, how do you choose them is a choice based on the surgeon's experience, availability of the implant, plus other factors that are there. But what is important is any type of surgery that is done, meticulous surgery and meticulous follow-up is extremely important. And choosing the surgery that is comfortable for that surgeon or has expertise for that surgeon, I think is very, very important. In some situations where there are difficult eyes, we cannot manage an intraocular procedure or a non-seeing eye where you want to avoid having the further enlargement or buophthalmos. Transscleral cyclophotocoagulation is a good choice. Some special situations. So this was a child who presented with a huge cornea, congenital glaucoma. When I took it up for a procedure, I was surprised to see that there was no pupil at all. So this child had a persistent pupillary membrane with pupillary block and enlarged corneal diameter, and you could see the Habs ray as well. So this child, I just did a pupilloplasty and tried to do a synechialysis as much as possible. Underlying lens was crystal clear, and through that on table we could do a fundus evaluation, and there was a 0.6 cupping. And since the cupping was not much, although the eyeball was enlarged, just a pupilloplasty was sufficient, and this child is doing well. So this was another such child with a syndrome, a Klippel-Trenaunay syndrome, who presented with a huge eyeball and multiple systemic anomalies, similar kind of presentation with pupillary block. And so basically there is no pupil at all. And when I did the pupilloplasty, I realized that there was a persistent tunica vasculosa lentis that was actually with a persistent pupillary membrane that was causing a pupillary block. So sometimes we should be vigilant about what the mechanism is and looking at the anterior segment, find out can you do a procedure that can take care of the problem and not do a routine trabeculotomy and trabeculectomy for these patients. Sometimes it could be just a vitreous blocking the pupil, and that has to be evaluated. So this people, if you see, there's some amount of peaking. So all I had to do was a little bit of an anterior vitrectomy, and that could take care of the pupillary block, and a little bit, and that could take care of the glaucoma as well. Sometimes spirophakia also can present with subluxated lens and high IOP. In situations like that, doing a lensectomy would be necessary. So to summarize, there are several options for the management of congenital glaucoma. Choose the best surgery as the first surgery based on the surgeon's expertise. And what is very important is follow-up care, and evaluation during the follow-up time is very, very important. Thank you so much for your attention.